Live and start the conversation.
Why? Of course. Yeah, man.
All right, we're live with my good friend Dr. Andrea Vidali from the Catskills and Kiltz from Sarasota down south in Florida.
Oh,
And
that's where you are.
yeah, I'm
Nice.
here. And we're on Carnivore Conversations in our background, but this is all about the Fertile Fireside Chat. We're talking about fertility and how important immunology and reproductive immunology is. And welcome, Dr. Vidali. How are you today?
Rob, I'm doing fantastic. It's a beautiful day, nice and fresh this morning. I'm sure you probably woke up at 3 a.m. since you normally wake up at 4 a.m. But
Well,
I
it
did
was
wake
it
up.
was 3 yesterday, but today was 4. No. It was the other way around. I did sleep in a little bit. I slept into 4 today, so it was good.
Okay. Oh, yeah. Just a long sleep. You slept late. You slept late, 4
I
a.m.
slept
Yes,
late. I
yes.
slept late. So we're here with our Fertile Fireside Chat, and we're going to integrate a little conversations. And it's all about health and wellness. And you've been in the fertility and medicine for a long time, Andrea.
Yes, yeah. I guess we both have been, let's just say we've both been around and we've seen a lot of evolution, right? When we first, when you and I first started uh, dedicating ourselves to the world of reproductive or infertility, if you remember, IVF success rates were abysmal, right? They were like
15 to
in
20% at
on a
best.
on a lucky day, on a good
Yes.
day, exactly,
Yes.
right?
Yes.
And it's an interesting history, I guess, because back then, we looked at things very different than we do today, right? And the reason why we look at things differently today is because back then, before doing IVF, since IVF was not very efficacious, we would uh, um, we would try to optimize things, right? Yeah, I think that was the philosophy, right? You'd want things to be as optimal as possible because IVF didn't. Sorry, there's like a truck, but it will go
Oh,
away.
it's
It's like
okay.
in the background.
It's good to have the background there.
Yeah,
It's good to
sorry
be out
about
in
that. I
nature too.
apologize. Yeah. So, but IVF, back then, if you remember, we would just do a lot of optimization before IVF treatments, right? We would just try to optimize everything. And that goes from nutrition. You'd want to make sure that everything was clean, no endometriosis, check the flow. It was really very aggressive, the sort of the optimization approach,
Mhm.
because IVF only added that 15%, right? Then things swung the other way, right? Where the idea was like, oh, IVF is so great, all you need is IVF, you don't have to worry about anything else, right? There was a time when, as IVF got better, that people thought, okay, all you need is IVF. Don't worry about optimizing. And I think things are swinging back in a way. Don't you feel that way a little bit?
I think we're beginning to talk more and more again about pre evaluation, things like endo and reproductive immunology, and maybe you could tell us a little bit about yourself and what got you into the area of reproductive immunology.
Well, I think first of all, we should take the opportunity to mention Dr. Jeffrey Braverman, because obviously he's not around anymore. And had he been around, I think even things would be even bigger. I think he unfortunately died. Has it been three? It's almost 3 years ago.
3 or 4 years ago, it's been a
Uh,
while.
and Jeffrey and I started working together. Jeffrey was a gynecologist in Long Island. He had like a very large gynecology and obstetrical practice. He was a general OBGYN, believe it or not, when he
Yeah.
started. And one day he called me up and he said, "Hey, Andrea, I've heard about you." And I had an IVF center already in the city. And and uh, and he said, "Well, I'm interested in fertility." And we started talking and we started working together. And he started doing IVF with me, but his big interest was immunology. Jeff was a genius, and he had a vision in a way that of the value of reproductive immunology. And the field of reproductive immunology has gone up and down over the years,
Uh-huh.
like everything. Like
Yes.
everything,
Always will.
like it's just like it's in medicine. Unfortunately, there's like fashion, just like the length of the skirts or the length of the hem of pants. Like things go in and out of fashion in medicine, and we could talk a little bit about that. But Jeff was like trying to tell me, hey, look, Andrea, there's like a lot about reproductive immunology, and we need to take it seriously. And he had a deeper understanding than most people. And I was your typical, if you will, traditional. What are these guys doing with those trucks?
No, we can't hear them. We really
Oh, you
can't.
can? Okay, good. All right,
you're good. We hear
Okay.
you.
Yeah, okay,
You're
good.
good.
So Jeff was I was your typical sort of traditional reproductive endocrinologist that, sort of I can't say I was ever narrow-minded, but let's say narrower-minded. And I had, like everybody, objections to the new, objections to ideas, and also objections to unorthodox ideas. Whereas, we have to understand that in medicine, we also sometimes have to embrace unorthodox ideas, because sometimes unorthodox ideas become orthodox later on.
Yes.
And
yes.
especially, and Rob, this is like, I'd like you to expand on that, because like, I'd love to hear what your opinion about that is, how this evolution of ideas happens in medicine.
Well, if you look at the treatment of gastric ulcers, right? So some guy had the gall to tell us that it was a microbe that was causing ulcers, and he drank the contaminated juices with the microbes, got the ulcer, and then took the antibiotics to clear it. So it takes some really strong ideas and strong people, but persistence. And that's the one thing that Jeff Braverman was. And you have become that same way and really have bought into something that still today, we're finding an uphill battle. But I would say that uphill battles are the only way to go, because you get to the top and you now can see the landscape of the land. But you're right. Opposite ideas in medicine and science are really difficult because we build our foundations on our belief systems.
Right. And the most important thing that we have to remember is this concept that I call of being selective bias, right? Like all of us have these cognitive biases, which are based on our knowledge system, how we have been trained, how we have the articles that we read. And one of the problems of medicine today is the fact that we're in a transition mode in medicine, right? What's happening. In fact, and I'll mention this in a second, this article I read today on the Lancet this morning, but we're in a transition where we're going from sort of like an older way of looking at medicine, in a sort of like scientific way, but very small-minded, the small study. Most studies in medicine are not randomized. They're not, they're very small studies, and even the randomized studies have a lot of biases built into them. But that's the best that we can do. But medicine, unfortunately, is the medicine knowledge base is not, in whatever field you look at, is not based on one gigantic studies that gives all the answers, but this myriad of little pieces of information. Where doctors have to put together all these little pieces, and then they make their own idea of what the truth is, right? It's sort of like a gestalt type of way of looking at things, where you say, I'm looking at these, and I can give you, many different examples, like, for example, is there a benefit of doing PGT for patients who are doing IVF? You can get contrasting opinion. There's some studies that show that after, the ESTEEM study, there's studies that can go against it for younger patients, but other doctors have a different opinion. There isn't one opinion, right?
Right.
Infinite, these little pieces together. And the same thing comes from the idea of reproductive immunology, which is the principle is extremely sound, which is the immune system plays a key role in implantation and ongoing pregnancy. This is an undeniable fact that none of us, no scientist can deny. And I think that is, so this starting point, which is that the immune system plays a key role in reproduction, is an undeniable fact. The second undeniable fact is that whenever the immune system doesn't work properly, and we know that because there are autoimmune conditions, lupus, lupus anticoagulant, syndrome, the antiphospholipid syndrome, and other autoimmune conditions. People who have these conditions in which their immune system doesn't work have troubles both getting pregnant and maintaining a pregnancy, and have a greater number of complications. So this is an example of a condition of when the system doesn't work, when the immune system doesn't work, then the pregnancy doesn't go on properly, more often than other cases. In other cases,
or the immune system is working and doing what it's supposed to do, and pregnancies get in the way, and that's it's sort of it's the immune system isn't the real culprit, something else is, and we're working to sort of identify inflammation based on these immunologic diagnoses and things like that.
correct. And the reason why we say that is that the the transition between the abnormal and the normal is a continuum. It's not a drop off a cliff. It's not a There isn't like a sickness cliff. In most ailments, whenever the system doesn't work, and I'm looking at that beautiful sky behind me, and it's real, it's not a background.
Oh, we're looking at it. We're enjoying it.
And the transition between health and sickness is always a continuum. So, and I've made this example before. You're not one day you're not non-diabetic, and the next day you're diabetic. It doesn't work like that. You're like a little bit diabetic, and then a little bit more diabetic, a little bit more diabetic, and finally you cross that line, which by agreement medicine decides that you're diabetic that day. But that's an agreement. We could have agreed on a little bit further out or a little bit earlier, but obviously we all have to agree on something. So in medicine we say when your glucose levels is 2 standard deviations beyond what the normal is, then you are officially diabetic. But it's not like 6 months earlier you're not diabetic. You were there, all the point and the same thing is for the immune system. The transition between out diagnosed autoimmune condition and a pre-autoimmune condition is always a transition, and we know that. There's lots of us are very aware that we have immunological weaknesses. It could be because because in our families there's a history of autoimmune diseases. And the thing with autoimmunity is that it's a family of conditions. So it's not like you have one condition and everybody gets the same. It could be that somebody in the family has rheumatoid arthritis, and then you're at higher risk for another autoimmune condition, or you're mildly autoimmune. So it's people have a knowledge in their family history, and also have awareness of certain symptoms that point towards autoimmunity, joint pains and other things like that, could be, or thyroid disease, things that are pointing towards autoimmunity. So we have to understand and acknowledge that a poorly functioning or a excessively active immune system doesn't necessarily mean that you have an autoimmune disease. And this is really the biggest confusion, right? Because we don't tell people, oh, you have some signs of autoimmunity, but you're fine. You don't have lupus, but you have some signs of autoimmunity. And if you've had reproductive problems, such as pregnancy losses, multiple pregnancy losses, especially with PGT normal tested embryos, or if the testing of the pregnancy was abnormal, or repeated implantation failures, this, amongst other reasons, could be due to the immunological problem. So we're not saying anything that's out of the ordinary or unimaginable or not biologically sound, right? I mean, I think that's really the key about that.
So
Please.
you got into the reproductive immunology field, led by Jeff Braverman at the time, a number of years ago, inspiring you to look at some things that maybe you and I weren't raised with in our standard reproductive endocrinology and infertility world. And what do you think? And I mean, Dr. Braverman, I honored him, amazing work, really a very, very brilliant man. What do you think that he brought to us, and what are the things that you focus on today that's helped grow this area?
Well, everything is incremental, right? I think that the biggest, in my mind, the biggest contribution that Jeff brought to this field was the idea of looking at the ongoing pregnancy. Pregnancy monitoring is something that Jeff really introduced, and I think was extremely innovative, which is the ability to actually forget about the initial sort of looking at the risk factor for pregnancy loss, immunological, and we can look at them in a minute. But I think pregnancy monitoring, so the ability of looking at the changes in the immune system, especially at the mediators of inflammation throughout the pregnancy, can be predictive of where the pregnancy is going. And what's interesting is that sometimes patients feel, whenever they've had a history of pregnancy loss, they know that they're about to lose a pregnancy. Mm-hmm. They feel the signs. And, you and I, having been doing this for quite a long time, sometimes the patient will come to us and say, look, doc, things are not feeling exactly right. I felt this before with my prior pregnancy losses. And I'm sure people have come to you telling you that. They will tell you, look, I'm feeling flared up. I'm feeling like waves of inflammation. I get all red. I get itchy. Not everybody, but some patients will tell you that. And you're like, sometimes you have a tendency to dismiss things because people are so traumatized when they go through fertility treatments that they worry about even the slightest signs. So it's very difficult sometimes to say, oh, this is important, this is not important, because people are really traumatized and they literally have post-traumatic stress disorder. But this is not a unique thing where people will tell you, look, this has happened before. I feel the signs of inflammation coming up, and then they lose a pregnancy. Well, those signs that people feel can also be measured, and when you measure those, sometimes you can predict. And if you can predict, sometimes you can bring in some corrective action. Sometimes, not all the time, because unfortunately, and this is the dilemma of
all disease,
of all disease, which is like the treatments bring in an incremental improvement, but not 100%. And this is really, it applies to everything, with the exception of, some things bring resolution. There are certain antibiotics kill certain bacteria. But when you're talking about most treatments, they all bring, in most cases, it can be significant, but it's incremental improvements. The important is that they're significant and that the treatments are better than no treatment. I think that's really very, very important, right?
Let me just take a moment, if I may, to everyone. We have some people live in the chat. This is the Fertile Fireside Chat. I've got Dr. Andrea Vidali, a fertility specialist, an endometriosis specialist, a surgeon, and also really prominent in reproductive immunology. So I'm Majestic, Rochelle, Amanda, Raven, and others. We're going to get to some of your questions. And maybe I could just throw in this one where maybe you can weave in some of these things. But let's see, Rochelle says a diagnosis with juvenile rheumatoid arthritis as a teenager, seemed to go away and went into remission when she was 19, now 32, and has had 2 miscarriages in a row. Could these things be related?
How about yes? A very big resounding yes. And what's interesting about what you're talking about is exactly what we were talking about, which is the immune system having these variations. And by the way, one of the reasons why, immune conditions vary, and I think we go back to also what you've been preaching for the longest time, is that we can affect our immune system. We can affect our immune system in a positive way and in a negative way. And there are many factors that affect it positively, but there are many that affect it negatively. So examples of negative effect, for example, stress can affect it negatively. But when you're on the diet side, huge impact of the diet in the immune system, because basically our gut is just basically a gigantic immune organ.
Yeah.
So these fluctuations are noticed, and I think I forgot what the name was. Michelle that asked the question.
Yes,
What was
yes,
that?
yes. Rochelle,
Yeah.
Rochelle.
Oh, Rochelle. And what Rochelle is talking about is a condition called rheumatoid arthritis, which is an autoimmune condition, which is associated with certain circulating autoantibodies. And it's usually a combination of antibodies. It's not just one. There's like different ones. And usually these autoantibodies are associated with a hyperactive immune system because what happens is these antibodies, whenever they circulate, they can activate certain cytokines, certain mediators of inflammation, and that in turn activates other cytokines. And because there is a natural tendency of the body in certain situations to reject a pregnancy, this rejection is amplified in the presence of autoimmune conditions, more specifically in this case, rheumatoid arthritis. So it's not surprising that people with like that have losses, and part of the problem that we have in medicine is that a very strict compartmentalization of specialization. So the rheumatologist doesn't know about obstetrics. The obstetrician doesn't know about rheumatology. The immunologist usually worries only about allergies. They worry about your asthma. They don't really worry about your pregnancy. The rheumatologist worries about your rheumatoid arthritis. They say they defer to the obstetrician. The obstetrician doesn't know immunology. So people are left in this area where very few people have an understanding of this stuff. I mean, you're one of them actually, Rob, and I'm sure that if somebody comes to you and tells you they have rheumatoid arthritis and they've had two miscarriages, you would certainly manage them more aggressively with your immune protocol, right? For sure. I mean, isn't that true?
Oh,
You would
absolutely.
definitely
Yeah.
do that.
So now she also has PCOS, which brings about metabolic disorder or a pre-diabetes, which is one of the most inflammatory conditions that we experience.
Right. So basically, in this specific case, the management should be one of first identifying what the active factors are on top of the rheumatoid arthritis, right? You would want to make sure that there's like the levels of antiphospholipid antibodies are not elevated. You want to look at first at the immunological factors,
Mhm, mhm.
and also you want to look at the histocompatibility factors. And here I'm going to talk about Pregimmune, which is a company that I founded, which is conflict of interest because I am one of the owners of this
Well, I
company.
invited you here to talk about this so we can better understand what testing is available, why we should do it, and then a little bit about maybe the treatment modalities. But
Yeah,
Presimmune, we've been using, and we're glad to have you on today because you're an expert in this area, and you can help us know because one is pre-testing to better understand it. It's essentially baseline blood testing to know where we're all starting from. And then with that, how do we monitor and measure over time? So maybe you could talk a little bit all of that related to
absolutely. So the first part of it is that you have to think about whenever you think about the immunology of pregnancy, you have to think about the first part is histocompatibility. How do the DNAs of the two partners fit? I'm using a simplistic term, but this is really what it's all about because what happens is that because the pregnancy is foreign to the body of the mother, uh, certain antigens that come from the father are easily recognized. Not all of them, but certain specific ones. And there is actual testing to be done that can identify these antigens. And it's done by doing what's called a high definition HLA test, which basically is the same test that you would get if you needed a transplant, an organ transplant. And that looks, we have, and then we match all the specific, the pertinent genes that then are coding for the pertinent receptors. And based on that, we can take a look and get a snapshot of the histocompatibility between the couple. I call them the parents. They don't have to be a couple. It could be a single person and a vial of donor sperm. It could be whatever. But I mean, the two elements at play, and uh, and um, and we look at that part that's called the histocompatibility part. And we look at different receptors. There's receptors on certain white cells, certain cells that are called natural killer cells, and these
Hmm.
receptors called KIR, KIR, and certain configurations of these receptors can be more triggering to an immune response to the pregnancy. We also look at what's they're called HLA, certain specific HLA matches in certain parts of the HLA. One of the better known is called DQ alpha, but there's also other parts of the HLA that are actually important. And whenever there's a lot of matches, which means that people are too similar, that can also have an adverse effect on the pregnancy. And we're also looking at the presence of high levels of anti-HLA antibodies, which is
Hmm.
whenever the body of the mother develops a high level of react, if she's had prior pregnancies, develops a higher level of reaction against the fetal antigens, but more specifically the paternal antigens, the DNA that comes from the father or from the sperm or from the donor, and what how those interplay. So we look that part we call histocompatibility. And in a person that's susceptible who has had multiple losses, if there are problems in the histocompatibility component, that could be a sign that that's a problem that requires some level of correction. And there's evidence that correcting these problems increases the chance of pregnancy, a successful pregnancy. The second part about that is the part that we call is broadly called inflammation. Of course, inflammation is a word that's at the same time overused and underused, right? It's overused in a sense that because it's such a catch-all term that it means everything and nothing, right?
Hmm.
On
Hmm.
the other side, is so incredibly important that if we ignore inflammation, we ignore probably one of the most important components of reproduction and overall health. But when we talk about inflammation, we really talk about all the different and how we study that. We're looking at about all the different signs of inflammation in the body, which includes looking at mediators of inflammation, which are cytokines. That one of them could be TNF alpha. We just talked about rheumatoid arthritis. That's a big mediator of inflammation. We could talk about certain other cytokines. They're called interleukins. We could talk about those. We could talk about inflammatory cells. We could talk about the white blood cells. And the thing about inflammatory cells is that one example is that could be T helper cells. It's like yin and yang, right?
Hmm.
It's not like certain cells are inflammatory, certain cells are non-inflammatory. It's not exactly like that. It's
Hmm.
just everything exists in a balance. So, for example, the ratios between two groups of what are called T helper cells, right? And how these two types of cells kind of interact with each other, the ratios. These ratios affect the level of inflammation, and there's inflammation on both sides. If the Th1 cells, Th1 helper cells, Th1 cells are higher, that's also a problem. Or if Th2 cells are too high, that could also be a problem. So there isn't like one of the reasons why things are sometimes are not as clear to people is that a low value can be bad or a high value can be bad. It's not like high bad, low good. It doesn't really work like that.
Can you talk a little bit about natural killer cells and where they fit into this testing and
Yes.
understanding a little bit about infertility and miscarriage? Because
Right. Right.
it's infertility and miscarriage because the same things that prevent you from getting pregnant can also cause you to miscarry.
Well, here's the deal. Because the immune system is never sort of like there's a homeostasis, right? It plays itself like that. Um, in order for the body, it's an important concept, but it's very important. In order for the body to have the proper reaction to the pregnancy in the very initial phases of the pregnancy, it is thought, there's agreement that there has to be a little bit of inflammation at the beginning, locally. And this is one of the reasons, by the way, that certain procedures like endometrial scratching that we do to try to enhance inflammation help implantation, right? What
Hmm.
people always like, what the heck? You're scratching, you're messing with the lining, and that helps. How's that even? That doesn't make any sense, right? You're messing things up a little bit and you're helping implantation. How's that even possible? But this is the logic, right? You're going in there, you're kind of like moving things around a little bit, and that causes a little bit of local inflammation. And for some patients, not all patients, that little bit of bump in inflammation helps implantation, as crazy as it sounds.
Yes.
Okay.
Yes.
And then as we progress with and we're like now at 4 weeks, right? We're like in the first week of pregnancy. Like, we're like in the first, we're like a week from embryo transfer, let's put it that way, right? And then after that initial inflammation has played a role, the higher level inflammation, we kind of want, tolerance has developed. So we don't want to have a lot more inflammation. So then at that point, a lot of inflammation is a problem. This is what you're asking was like a great question, by the way. And it's funny, nobody has ever asked me this question, but it's a fantastic question because it helps us understand certain principles. For example, certain people implant, they tell you, I get pregnant every single time, but then I always miscarry, right? Maybe these are the people who have that little bit of extra inflammation. It's starting to rain, so if it rains a lot, I may have to
And
move
you got to
somewhere else.
move. Well, don't worry about it. You got to move. You got a
But
place close by.
yeah, I do it. Yeah.
It's
So,
okay.
so,
If we
so
want
when
to,
no, we're good. I'm good. I'm just gonna go like under. So if you have a lot of inflammation, then in the second phase of the pregnancy, this could be a problem, right? And that's why you can't just base things on one test or. And the second thing that I think is important in this consideration that I just made is that even when you give immune treatments, and this is one of the reasons why sometimes some doctors keep on going up on the treatments, giving more and more and more, right? And this is not necessarily always a good idea because there could be a point where, sorry guys, here I am. Okay, I've reached a less rainy position. And there can be a situation where actually, for example, if you suppress too much, then you prevent implantation, right?
mm-hmm.
And this is one example where people will tell you, "Oh, I had miscarriages. I was getting pregnant all the time, and now I'm not getting pregnant because there has to be a little bit of titration.
Mm-hmm.
Like you don't want to suppress people too much, but you want to suppress enough. And so this is why sometimes it's a little bit of a tricky, and it can be a little bit of an art trying to figure out the right thing. But I think that was a beautiful question, and the answer is that yes, a little bit of inflammation is important in the early phases of pregnancy, and I think that's really a fantastic question, and it helps us understand a little bit better the immune system, I think.
So in doing the Prejmune testing,
Yeah.
which is a battery of testing of both
Mhm.
the implantation environment
Yeah.
and also the sperm source. I mean,
Right.
that's really the two areas. The egg source itself, if it's a donor egg, is it as critical or is it also important?
Donor egg is critical. I mean, here's the deal. You're looking at two elements, right? One element is going to be the person, right? The carrying the pregnancy, and then you have all the outside elements, right? And it's a big question that we get all the time is that what if I had instead of using my own egg, I use a donor egg. How is that going to change my chances of implantation? All right. And the answer to that is it depends. It depends on what the problem is. If the problem is specifically on the inflammation or immunity side, using the donor egg may not necessarily change things a lot. But if on the side of the histocompatibility, things could change a little bit. You know what I'm saying? Because, for example, you're bringing in, newer antigens that could be easily recognized, and you could get like a pretty good shot the first or a second time, before these antigens get targeted. So, it depends on the situation, but it's certainly an important one. And do we recommend testing for people that history to test the donor? No, we don't recommend it because realistically speaking, in the first or second time that you do this, you're less likely those antigens are less likely to get targeted.
So testing wise, all right, who
Yes.
should get testing? When should they get testing? And tell us a little bit more the importance of the
Yeah.
battery of tests.
Yeah. So, one of the things that, it's interesting. I was looking on Reddit the other day, and there were some people, expressing doubts about, oh, the testing, my doctor can do the testing. The testing, of course, the tests, the PregImmune tests are available. You can order most of those tests. If you know what tests to order, you can go to a lab and order those tests. Okay. It will cost you the same money because in the case of PregImmune, PregImmune doesn't make money from the lab. The lab is a private lab. It's a public lab. It's LabCorp and Quest. So, that's how labs are labs. And part of the problem is that with the panel of testing is whenever doctors order immune testing, every doctor orders something different. Most doctors order a smaller panel that, did I lose something?
No, we got you.
Okay, sorry. Some people order a smaller panel that the lab recommends them what to order. And so really, one of the difficulties is knowing what labs to order, which can be overcome. And the other part of it is that how to look at the results of the labs once you have them in your hand. Because look, doctors were all busy, right? You get these 20 pages of testing, you're flipping through the pages, this is high, this is low, this is it just like most of the doctors will end up looking at these lab results and don't even know how to interpret them, right? They're going to say, oh, this is high, must be bad. Well, I don't know about that, right? Maybe high is good. I don't know. The question here, and for some of these labs, there aren't any really standard values. It's not like a diabetic test where glucose high, bad, So, and the other part of it is that more often than not, the doctors ends up having to make this, what we called earlier, that gestalt type of analysis where, put your hand in your mouth and say, this doesn't look good. It stinks. Doesn't, you don't really want that. You want sort of like an in-depth analysis of what's going on and be able to tell the patient, like I do, is I could tell them, look, this is more of a histocompatibility problem. This is more of an inflammation problem. And the solution is most likely to be one thing versus the other. So I think what PregImmune really does, it really helps doctors make these decisions and get an analysis and say, the first question is that, does the immune system play a role in this specific recurrent pregnancy loss or implantation failure? Yes or no? In the case of no, then we move on to something different, right? Move on to a different approach. If it plays a role in the thing, is this a severe problem or a simple problem? And with this, we use artificial intelligence to get a little bit better insight into the problem because, as you guys know, without AI today, it's very difficult to make complex decisions.
How did you develop the PregImmune panel, and why did you decide on using this? I mean, you didn't take 5 patients and put this in.
No.
You mentioned AI. So maybe
you
could talk a little bit about that.
Yeah. The way we developed the panel is that we looked at the panel comes from basically a decade of work and also in the work of sort of the most established reproductive immunologists, people that have been doing this for a long time. So it's kind of like the gold standard of care in reproductive immunology. So that's how we got to that initial panel. Like everything, you have to look at, whenever we were looking at things, we realized, wait a second, we need to start looking at this data in a way that helps us predict things. But whenever you have a lot of tests, it's a little bit harder to make predictions because even when you do a multivariate analysis, the multivariate analysis could tell you this, 3 things are important, but you still don't know, and because you have to always look at things holistically. And this is one of the problems. And by the way, small digression, but I'd like to make it if you don't mind.
Please.
This article today on the Lancet by the group of artificial intelligence in medicine people from the Brigham and Eric Topol from the Scripps Institute, and I'll share it with you. You can share it with your followers, on your Facebook afterwards. I'll share the paper with you. It was very interesting because it's looking at using artificial intelligence for embryo selection in IVF. Which, is very interesting because until now, you're basically relying on the eyes of the embryologist, which is a human being, to tell you, yeah, the embryo was dividing correctly, the embryo looked good. It's us reproductive endocrinologists are always like, we're basically dependent on what other humans tell us, right? What the
Right.
embryologist tells us, well, based on this grading, and I look with my own eyes, this embryo is good quality, bad quality, and we're always like perplexed, right? We're always like, what does it mean? Is it like a pretty looking embryo? In a way, it is, right? It's a pretty looking embryo. But what's happening with AI is that they're putting these embryos from actually they're going from the egg to the sperm to the embryo to how the embryo grows in, and they take literally like millions of photographs, and they have artificial intelligence analyze those embryos, and then they're using AI to predict which is the best embryo to transfer. Incredible stuff, really. Which and why is this better than a person looking at it? It's because it's so much more powerful, right? And also like embryo, it looks at things that you wouldn't have thought that are important. And also there could be things that actually our mind makes us think they're bad, maybe they're good. So because we always think, maybe I'm just giving an example that is not in this paper, but and it's not a fact, but we
Mhm.
could think that maybe a little bit of fragmentation may be good. We don't know that. Maybe an embryo that has no fragmentation is worse than an embryo who has a little bit of fragmentation. This could be true.
So what we're
Like,
working to do is pick the one embryo that we think is the most likely to implant to become the baby, to minimize the number of cycles people go through. Is that correct?
correct. I mean, ultimately, this is where IVF is going. Is mostly, which is it really a good thing? We could talk about that. Maybe it's not a good thing, because what happens then is that if the person transferred that embryo and it doesn't result in a pregnancy, people go crazy because they invested so much in that and now it doesn't work. And you're like, what now? Well, usually the answer is reproductive immunology, of course, but you know, I think is that that's the direction that it's going. And the problem with that is that today, only about, when you look at the world statistics, okay, uh, believe it or not, in parts of Spain, 1 in 10 pregnancies are IVF pregnancy. 1 in 10, Rob, 1 in 10.
Huge, huge, growing.
Enormous number, ridiculous. You know how many in the US?
1%.
No, it's about 1 in 50, actually.
Well, okay.
It's about
I
two, yeah,
mean,
2%, I guess. Yeah,
it's
yeah.
going up too, but maybe,
Yes,
but that's not a sign of a good time. Maybe that's a sign of lots of trouble still going on. And I think that's why what you're talking about is so important, because inflammation is rising. All diseases are going up. Infertility is just another one of those things. And how can those that are suffering from repetitive losses, one loss, and being infertile, not getting pregnant at all, how can they solve their stress and struggles of this journey in a more reasonable way? And maybe more and more people should be getting the immunologic testing as part of the baseline testing of being infertile.
well, you see, part of the problem, I noticed that when I was talking to you about the AI selection of the embryo, is that with the current push of optimizing everything in the embryo transfer, right? Basically many people doing PGT testing, and then the ERA and the receptiva and the endometrial biopsy and the EMMA and the this and the that and all these testing, right? So basically, sometimes people have to do 2 cycles to get a good, one good embryo PGT tested. And they've done all this testing and they finally are getting this embryo transfer. They're finally getting there. If it doesn't work, it's become a tragedy of epic proportions, because there's so much loaded on a single embryo transfer. And you guys,
Oh, we lost you a second. We lost Dr. Vidali for a moment. He'll be back. There we go. Maybe can you hear us? All right. Thank you very much for joining us, everyone. Appreciate that.
Sorry, I
No,
had
there you go.
lost you.
Yep,
Can
you're
you
back.
hear me?
Yep,
Okay, sorry about that. Okay,
yep, yep, yep.
yeah. So
Your arm's probably getting tired. How you doing there? You don't have a
I'm
place
good.
to
I'm
sit?
good. I'm good. I'm doing great. Yeah. Can you still
Okay.
hear me? Because I
Yep,
lost my earphones. Yeah, yeah.
we
So,
got you.
so one of the things that I think is very important to remember is that because there's so much loaded, embryo transfers have become so loaded. It used to be that a failed embryo transfer used to be a sad moment, a disappointment. Today, a failed embryo transfer has become a tragedy of epic proportions.
It is. Yes, yes.
And I'm not blaming people because they put literally everything they have into one embryo transfer.
It's expensive physically, financially, emotionally, and that's why it's important to sort of integrate these ideas of what can people do. Where should they go to? What's your website? Are there's information through your website that people can learn more about reproductive immunology?
Well, I think of course, I like to point people to Pregmune because that's the website that Pregmune has, which points to how to do the testing. But I think that the website where they'll find a lot of information is preventmiscarriage.com, which is my own personal website, that was started by Dr. Braverman. And that's, I just want to make it very clear, we do not do IVF. We're not an IVF center. We don't do any of that stuff. We just look at the immunological part of things. And that's really what, we are dedicated to. And but Pregmune.com is the website where if you want to do the testing, and you've been using the testing successfully
For a number of years. Absolutely.
and you are one. And let's just say that CNY is, what are you, like the third largest center in the US now or something ridiculously big, right? You guys are so big now.
We do a lot of cycles, and we're really interested in helping more and more people get babies even without us. That's why this information, what you're sharing on, we put a link, Erica Gillum put a link. We're going to put a link here, preventmiscarriage.com. Was that it?
Yeah, preventmiscarriage.com. And what's interesting about what you guys are doing, that you are one of the first people embracing reproductive immunology. Let's just say it as it is. Number one, honestly, you were the first one offering immune treatment to patients and treating people with immune treatments. And you were one of the first ones who saw these problems. And, now you correct them in various ways, of course, nutrition. But your approach has always been anti-inflammatory, looking at everything holistically, because you understand what kind of pressures your patients are under. Ridiculous pressure.
So you've been working with Dr. Braverman, and we got to mention Dr. Alan Beer also, because he was around even before that, and there's some others before that.
100%. I like to mention also Dr. Kwak Kim. There's other doctors.
Yes.
Yeah, there's other doctors out there practicing reproductive immunology. We're not the only ones. I got to make it very clear. There's some excellent doctors practicing reproductive immunology all over the world. Not as many, but there's a good number, so I just want to make sure, yes, that there's awareness about that.
When it comes to cancer therapy, it's all immunologic treatment now. Look at the inflammatory, because COVID, even a vaccine essentially is a immunology treatment. If you
can't ignore the immune system. That's the reality of it. You could try, but you can't.
You can't let it go. You can't let it go. We're gonna bring you back again, by the way, and we're gonna be on another 10 more minutes if you're still good with this.
Absolutely, yes.
If some big storm's gonna take you down, we understand if you throw it away and run.
We're good. I'm doing good, but I just like to just comment a little bit about. We were talking about the mega pressure that people are under, and and how. I think the push to optimize things is a very good one. But also you have to put things into perspective, right? Because I think one failed embryo transfer, unfortunately, even with the optimization, is a possibility. it's tragic, it's stressful, but no matter what, it could still happen. You know what I'm saying? So I think that it's very hard. It's a very hard thing to deal with, and it's just but it's still a possibility, and things happen because there is a statistical chance of failure built into the system, which is not due to sometimes it's not due to anything specific.
So through us at CNY, we can help with pregmune testing. And once you're pregnant, it may be important to do this on a regular basis, every 2 to 4 weeks.
Correct.
And adjusting your medications throughout your pregnancy, because
Yes.
it might not be, hey, you're pregnant, great, see you later. It really is important to continue the observation, the monitoring, and treatment throughout the pregnancy.
I agree. And, you and I both have seen in some of our patients who have had multiple pregnancy losses, they do experience a higher number of pregnancy complications than the average patient. So one has to be alert about it. There's no question about it.
Well, those that are seeking IVF, in general, they're infertile, repetitive losses, they have inflammation. And so when you put an embryo in there, they're at that higher risk. And we do know that. When it comes to, I just asked about natural killer cells a little bit.
Yeah.
And can you just give kind of a little sentence of what your
Absolutely
thoughts are on NK cells? Because that's a big buzzword.
The most important natural killer cells are the uterine natural killer cells. Okay. Because whenever an antigen enters the uterus, that antigen is recognized by certain cells in the uterus. They're called antigen presenting cells, APCs. And these antigen presenting cells then present these antigens, these paternal antigens from the father, to other cells. They're called dendritic cells. Nobel Prize was given, I think, 20 years ago for the discovery of dendritic cells. And these cells then in turn present to natural killer cells, uterine natural killer cells, that then regulate the immune response, the uterine immune response to the pregnancy. Okay. So it's a cascade. Okay. From this knowledge about natural killer cells, people have started measuring serum natural killer cells, the ones in the blood. Okay. And there have been some studies showing that very high levels of natural killer cells, but also very low levels of natural killer cells can be associated with recurrent pregnancy losses. But unfortunately, there's very little correlation or no correlation between serum natural killer cells and uterine natural killer cells. And measuring uterine natural killer cells is very difficult because, you have to go into the uterus and people are pregnant. You can't really take those cells. You can do it in a non-pregnant state, but there's really no really good ways to do that. There are some tests where people do an endometrial biopsy and look at expression of certain antigens. Mm-hmm. It can be France and can be done, but it's not, it's still not as good. So in general, levels of natural killer cells per se are not extremely meaningful. And lowering natural killer cells in the serum may do nothing to regulate uterine natural killer cells. And there's no evidence that if you really lower natural killer cells in whichever way you can by, giving immune treatments, you actually change drastically much in the outcome of the pregnancy. This is why we don't really focus too much on natural killer cells. Mm-hmm. It's a very important thing. Unfortunately, they have a very sexy name that's very attractive because killer, you're like, yeah, get the killer.
We got to get those down because those are going to take us down.
Killer. But it's not like that. So, yes, it's an important parameter, but also the way that natural killer cells are measured, there's this test called NKA or natural killer activity, which mm-hmm. is an in vitro test. But, I compare natural killer activity to a test we used to do in fertility many, many years ago, which used to be the hamster egg sperm penetration assay, right? You take a sperm and try to make it fertilize the egg of a hamster, penetrate the egg of a hamster, which revealed itself to be a completely useless test, but people still did it for the longest time, right? In the longest time. So a lot of these stimulation, these in vitro tests are not very useful. So, I would tell people, don't worry too much about natural killer cells. This is not where the money is when it comes to reproductive immunology and infertility. Certainly not serum natural killer cells.
I'd be remiss if I didn't talk a little or ask you some questions on endometriosis. And someone asked early on about hidden C and silent endo.
Right.
Maybe you could talk a little bit about those that
Yeah.
have.
I think a very important question. And I think that silent endometriosis is a big issue because what that means is endometriosis without the classic symptoms. Although I said this many times before, if you start asking the questions, many people have some symptoms. It's silent because people have gotten used to tolerating the problems and the symptoms. But, there is such thing as, even when you ask the questions, people don't have any symptoms of that. And the big question is, whenever there's and there's two possibilities with endometriosis. One is that it's visible on imaging, so you have evidence of endometriosis. Although it's silent, you look with the ultrasound, you see endometriomas, you see endometriosis although there aren't symptoms. And then there's people that there's no evidence of endometriosis on imaging. And the big question is that how much of a role does that endometriosis play in natural fertility and IVF? When it comes to natural fertility, we know for a fact that endometriosis, even in minimal amounts, plays a role in infertility. So removing the endometriosis increases the chance of natural pregnancy. I think the bigger question is that how much does minimal endometriosis play a role in IVF? And the answer to that question is that we don't know. There isn't a clear answer to that question. And people sometimes come to me and they tell me, well, I tried, I failed on one IVF cycle, or they haven't even done IVF. And they get before they do a transfer, they get an ERA test. It comes back, sorry, an ERA, a Receptiva test. It comes back positive. And they're like, well, shall I do surgery? And I'm like, look, you've never even done a transfer, I mean, and that depends on the person. And this comes down to the science. If we stick to the science, the answer is not really clear there yet.
Mm-hmm.
Could be either way. If you instead want to say, well, I'm a maximalist and I want every single test on the face of the earth done and every single intervention before I do my embryo transfer, I mean, that's your prerogative. I don't think that's necessarily a wrong approach, but in theory, I always tell people the NNT, the number needed to treat to probably get an extra pregnancy with people with minimal endometriosis, like the small amount of endometriosis, is 8. So you have to do 8 laparoscopies to get an extra baby. I mean, it's still a significant number, but it's not that, it's not a huge number. I want to make it very clear.
But we're talking about the individual, and we're taught to treat populations, but ultimately we're treating an individual.
Correct.
That's where I think the problem with science gets in the way. These ideas that well, we haven't proven it, but if you got cancer and you're going to get a 1% improvement in your outcome, you may take that. Or
you may not take that. It all depends on what the treatment is, right?
Of course, that's it. And laparoscopy is not without risk either. But in skilled hands, it's probably a lower risk. I would think.
Correct. And I think that's the way we look at it. So, which is there is patient autonomy. There is, and people, patients always ask me if for some reason the people, whenever I recommend an intervention, sometimes people tell me, okay, if that doesn't work, what do we do next? It's a very good question, by the way. I like it when people ask that question, right? Because, let's say you recommend a treatment or not doing a treatment. And somebody tells you, okay, let's pretend we did it. What do we do next? And usually the doctors are like, well, let's wait. We don't know what we're going to do next. Maybe, I think maybe doctors should think about that. So if a patient tells me, look, let's say that I don't do a laparoscopy to look for endometriosis and then the implantation doesn't work. What do we do next? I'm like, well, then you do the laparoscopy. And then the patient will say, maybe they say, well, maybe I want to do it, So I think that, that's one way to look at it, at things. And you're absolutely right. We're treating human beings, we're treating individuals. They have their own autonomy, their own personal medical histories. And so as limited as it is the reality of our work as physicians and also as human beings. And I think that when we ourselves have a medical problems, we think the same way, we act the same way, we want the same things as everybody else, and we are in the same chair, in a different chair, but we're on the other side of the chair.
So many suffering from infertility, and the majority of them aren't using IVF. So I know that the preventing miscarriage is important for everyone, and IVF isn't the end all and be all for everyone. And so doing the immunologic evaluation, pregimmune testing, can be important for anyone doing standard fertility care or pregnancy naturally or IVF or IUI.
100%. Like I've seen people, for example, who have had multiple losses and they had testing of the products of conception and they were normal, genetically normal babies. And, they go to the reproductive endocrinologist, the endocrinologist offers IVF with PGT. And I'm like, and they keep on miscarrying, and I'm like, well, that's just, and so like, that's really the question. Somebody's talking about ketosis here.
Well, we're getting lots of comments on the sidebar, and I want to just put them up. Let's see. The important was we were highlighting your website. Erica was kind enough to make sure we have that. Is that correct?
Oh, fantastic. Thank you so much, Erica.
Miscarriage.com. And I just,
pregimmune.com.
We talk a lot about nutrition. I mean, nutrition to me, it's faith and fertile fatty foods and ketosis and ketogenic. We're going to be interviewing the Sophie Clemens from Hungary, Paleomedicina, where they're doing a lot of work with the fasting and keto, paleo, and carnivore in curing all diseases. And it's all immunology, right? And
it comes down to that. Yes,
that's it. And interesting,
it's manipulation of the immune system via diet. That's it.
It's it. And again, we want to congratulate. And again, thanks for Eric and others for really sharing. We want to share that, and thank you. This is such a pleasure to have Dr. Andrea Vidali here today, and from the where are you, Poconos or
Catskills.
Catskills. All right. I knew they're close.
Yeah. Otherwise, I would have been speaking from a very large champagne glass inside a champagne glass. Then you would have known I was in the Poconos.
Good point. And there were some comments there. Alcohol is not good for us at all, and it affects pregnancy. And we talk about a lot of low dose naltrexone. Any comment real quick about, there's not one treatment for everyone here, is there?
Well, ultimately, treatment has to be individualized. I think the knowledge has to be expanded. I feel that ultimately artificial intelligence will help us, but it also, to some degree, it will also take away autonomy to some degree, unfortunately. It's a little bit, I always tell people, it's a little bit like your GPS, right? Your GPS uses AI and predicts, like you'll get, you're driving from Boston, you'll get to New York in 2.5 hours based on this statistical analysis, blah, blah, blah. And the GPS is right, but sometimes the GPS is also wrong, because things can happen on the way, and you end up getting there an hour later than the GPS predicted. But the GPS adjusts continuously. So I think that's, a little bit of philosophy at the end, but I got to run because it's really starting to rain now.
All right. Listen, we love you. We'll talk later this week. And we're going to do this again and integrate and go from there. God bless to everyone. Thank you for joining.
Thank you so much. Thank you so much.
All right. All right. Thank you to everyone for being on today. And I may not have gotten to all your questions. I'm so sorry if I didn't, but really grateful to everyone. A blessing. Thank you, Erica. Thank you, Kim. Yes, and a little on pregimmune.com. And let's see, cancer cure ketosis is the key for sure. And fibroids. I'll just go through a few quick questions. Myoma is an HPV virus. How does it work on the cells? Well, the viruses are inflammatory, and fibroids are just inflammatory tumors that have grown because of some cause, whether it's a virus, a microbe, but other antigens like leptins, oxalates, phytates, lectins, oxalates, and phytates. Lots of sun in Greece. Giannis, thank you. Let's see. Good morning. Good morning. Saying hi before on your way to work, Kareem. Great. Parminder, hello. We wrote the website. Awesome. Yes, yes, yes. Let's see. We request this at CNY built in. You can ask for the Pregimmune testing for sure. We'll order it for everyone. It gives you a full readout. It's a lot of really great information, and we will help guide you through the treatment. Karen from Australia, Western, thank you very, very, very much. Appreciate it. I'm just scrolling through, making sure I've gotten to as many questions as can be today. Let's see. Low dose naltrexone, LDN. We've been using it for years. Phil Boyle out of Ireland. Take a look at Phil Boyle, Ireland. It's anti-inflammatory. I like the 3 milligram dosing, by the way. Let's see, Patricia. Let's see what we have there. Let's see. I only do natural cycles, and we'll consider IUI next year. Again, look at our website, drkiltz.com, cnyfertility.com. You can click on Pregimmune, on preventmiscarriage.com. We'll have all of those. And don't forget the baby's way. It's important for all of us. Alcohol is deadly for all of us. Red wine, not good. White wine, not good. Heroin, cocaine, marijuana, all deadly for us. Facebook, thank you. Wake up tired anymore. Listen, I think LDN, but ultimately meditation, prayer, and gratitude, right? That's it. 5 weeks, Facebook. Awesome. All right, everyone. Thank you. Let's see. Any other last minute questions? A hidden C testing. I just say you can do the hidden C. You can do looking for endo, looking for HPV, chlamydia, and all of these things. Treatment, Levaquin, Flagyl, Valtrex, Diflucan, at least 30 days. Z-Pak, Doxy can help also. Carnivore, make your, see, some hydrosalpinx are just adhesions around it. Your body may help take them down, but this is where laparoscopy may come in also. Let's see, acceptable biosimilar for Humira. I don't know if there is. There may be some others, so you gotta hunt it out, Amanda, and we will be glad to help and use that for you. All right. Blessings and God bless. It was nice to have Dr. Vidali on. We'll do him again. Oh, let's see, Alexandra, I'm glad I saw that at the beginning. Diverticulosis. Listen, I used to have it, went away on the baby's way. 1 meal a day, 23 in 1. And listen, occasionally French fries, occasionally a pancake, but rare in small amounts from time. Oh my God, maybe once every 6 months. Right. Blessings to you all. Samantha, Alexandra, Amanda. Yes. Mononuclear cells versus platelet-rich plasma. Ooh. Peripheral blood mononuclear cells and platelet-rich plasma. You know what? I don't know how much is really different there. I'm going to have to look that one up. But high in platelet-rich plasmas, and you get rid of a lot of all those antigens also. Let's see. All right. Thank you, everyone. I'm catching a plane up to New York. I'll see you tomorrow. God bless you, my friends.